Welcome to this presentation on pneumothorax. What is a pneumothorax? Pneumothorax refers to accumulation of air in the pleural cavity. So in this X-ray, you can see normal lung fields on the left side. On the right side, there is complete absence of lung markings and there is a collapsed lung with sharp margins. So this is an example of a pneumothorax. According to its origin, pneumothorax may be classified into traumatic, iatrogenic, and spontaneous. A traumatic pneumothorax might result, for example, from a road traffic accident leading to trauma to the lungs, which results in leakage of air into the pleural cavity. Iatrogenic pneumothorax is pneumothorax due to a medical procedure, for example, during the insertion of a central venous catheter. When there is no obvious precipitant, the pneumothorax is referred to as a spontaneous pneumothorax. A spontaneous pneumothorax is further classified into primary or secondary. A primary pneumothorax refers to a pneumothorax occurring in a patient with normal pre-existing lungs. A secondary pneumothorax refers to pneumothorax in a patient with an underlying lung disease like COPD. Small pneumothoraces may remain asymptomatic. However, most patients present with chest pain or shortness of breath or both. The chest pain is usually sudden in onset and pleuritic in nature, meaning that it is worse when the patient takes a deep breath in. One should inquire about comorbidities as that helps in classifying the pneumothorax into primary or secondary. Smoking history should also be inquired. Examination should be quick as this is an emergency presentation. An assessment of airway breathing and circulation must be done, as some of these patients may have tension pneumothorax, which results into hemodynamic instability and requires immediate management. In a patient with pneumothorax, the examination of the respiratory system may reveal reduced expansion of the chest on inspiration on the affected side. On percussion, there may be a hyperresonant note. Vocal fremitus and vocal resonance are diminished on the affected side, and on auscultation, breath sounds are usually absent. Among these, absent breath sounds and a hyperresonant percussion note on the affected side are the two most important clinical signs that help in establishing the diagnosis of pneumothorax. The diagnosis is usually confirmed on a chest X-ray. So in this X-ray, you can see a sharp margin of the collapsed lung on the left side, and beyond the margin, there are no lung markings. The size of the pneumothorax is often expressed as the distance between the collapsed lung margin and the costal margin at the level of the hilum. Occasionally, in some patients, a pneumothorax may be confused with a large bulla. Whenever there is a diagnostic dilemma, a CT scan may be done to resolve the dilemma. However, in most patients, the diagnosis is confirmed on a chest X-ray. This slide looks a bit complicated, but if you look carefully, it's not that complicated. It has been borrowed from the British British Thoracic Society guidelines for the management of pneumothorax. Patients who have hemodynamic instability should have an immediate chest drain insertion. Also, patients who have bilateral pneumothorax should have a chest drain inserted immediately. In all other patients, we should follow this flow chart. So, the first thing that a clinician needs to decide is whether this is a primary pneumothorax or a secondary pneumothorax. So, if there is a history of pre-existing lung disease like COPD, or the patient's history and chest X-ray are suggestive of pre-existing COPD, or in a patient above the age of 50 there is a significant smoking history, then the pneumothorax should be treated as a secondary pneumothorax. A secondary pneumothorax is managed more aggressively than a primary pneumothorax, as these patients are less likely to tolerate it well. So, in the case of a secondary pneumothorax, if the patient is breathless or the size of the pneumothorax is more than 2 centimeters, then a chest drain should be inserted and the patient should be admitted. In those patients who are not breathless and the size is less than 2 centimeters, we have to decide whether the size is less than 1 centimeter or it is between 1 and 2 centimeters. If the size is between 1 to 2 centimeters, then the pneumothorax should be aspirated with a needle. Up to 2.5 liters of air can be aspirated in one setting. If this aspiration is successful, which means that if the size is now less than 1 centimeter, then the patient should be admitted and observed for at least 24 hours. They should be given high flow oxygen except in patients with COPD, where oxygen needs to be given with caution. If the initial aspiration is unsuccessful, then a chest drain should be inserted. Also, those patients in whom the size of the pneumothorax is less than 1 centimeter and they are not breathless, these patients should be admitted for observation for 24 hours and given oxygen. Once again, if the patient has a history of COPD, then oxygen should be given cautiously. So this was the management of a secondary pneumothorax. In patients with normal underlying lungs, that is, patients who have primary pneumothorax, the management is again decided on whether they are breathless, and whether the size of the pneumothorax is more than 2 centimeters. If they are breathless or if the size is more than 2 centimeters, then an aspiration should be attempted. If the aspiration is successful, meaning that the size is now less than 2 centimeters and the patient's symptoms are better, then the patient may be considered for discharge or may be admitted for a brief period of observation, and they should be reviewed after 2 to 4 weeks with a repeat chest x-ray to ensure full resolution. If the initial aspiration is unsuccessful, then chest drain needs to be inserted. Patients should usually be advised not to fly for at least 2 weeks after the event, and a chest x-ray must be done to ensure full expansion of the lungs before they take a flight. Some patients have recurrent pneumothoraces and they should be referred to a specialist for consideration of procedures like pleurodesis. This is a schematic diagram of a chest drain. So the drain is on the one hand connected to the pleural cavity and on the other hand to an underwater seal. And during expiration, you can see the bubbles coming out. Before we end, a quick word on tension pneumothorax. Occasionally, the connection between the airway and the pleural cavity acts like a valve when air can leak into the pleural cavity during inspiration but cannot be reabsorbed during expiration, and this leads to rapid accumulation of air in the pleural cavity, leading to mediastinal shift and hemodynamic compromise. These patients are severely breathless, the blood pressure starts dropping, they have significant tachycardia, they may be cyanosed, and the trachea may be shifted to the other side. They need immediate attention. The treatment is a chest drain, but to buy time, a wide bore intravenous cannula may be inserted in the second intercostal space in the midclavicular line. This gives them immediate relief so that a chest drain can then be inserted. Thank you.